Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. Happy New Year, everyone. For our first episode of 2023, we talked to Dr. Bhaskar Gurram. Dr. Gurram is a pediatric gastroenterologist specializing in inflammatory bowel disease at Children's Medical Center Dallas and UT Southwestern. We talked to him a lot about the genetics of inflammatory bowel disease and genetic research. We talked to him about health maintenance for kids with inflammatory bowel disease. We talked to him a lot about C. diff and why people with IBD may be more prone to it and the treatment of. And finally, we talked to him about the language we use around treating inflammatory bowel disease and how to ensure that people have a more successful IBD treatment. Cheers.
Hi, everybody. Welcome to the show. This is Robin.
Hey guys, this is Alicia, and we are absolutely delighted to welcome Dr. Bhaskar Gurram. Dr. Gurram, welcome so much to the show. We're very excited to have you. Before we have you introduce yourselves officially to everybody, though, we're going to ask you the very unprofessional question of what are you drinking?
Okay. Hello. Good evening, everyone. My name is Bhaskar Gurram. I'm one of the gastroenterologists at Children's Medical Center Dallas and UT Southwestern Medical Center. And thank you, Robin and Alicia, for inviting me for this podcast. Truly appreciate it. What I'm drinking right now is kombucha. Kombucha is sort of a fermented tea. It's, popular in non-alcohol drinkers, I guess. So this is my sort of replaces the alcohol, but something I really like and enjoy.
It's office friendly as well, which is good.
That's correct. That's correct.
Is it flavored? I mean, because a lot of times there's a flavoring with them.
Yeah, well, it's the base is a fermented tea, and then on top of that, it is flavored with, for example, the one I'm drinking has apple, turmeric, carrot, and several other spices.
Oh, wow. All right. It sounds very healthy.
Yes. Well, I will, say probably. Yeah. It's better than any other soft drinks, I feel. Yeah.
Yes. It doesn't take much, but yes, definitely better than those. Robin, what are you drinking?
I am drinking a refreshing glass of lemonade.
Oh, I'm drinking alone tonight. Oh, dear. My neighbor gave me this recipe, so I'm pretty excited. It is a winter cranberry gin fizz cocktail.
Ooh.
Yes. So I had to make my own simple syrup and stuff. I mean, it was a process, but it is pretty delicious. So I'm very excited. Well, Dr. Gurram, thank you again so much for joining us. We are very excited to have you on the show. Second question we always ask everybody is, why did you choose gastroenterology? Why IBD?
Okay. So I came to United States for actually doing advanced training in genetics. So after finishing my residency in India, so I have two residencies overall, one in India and one here. And after coming here, I think looking back, I made the right choice by again redoing pediatrics. I had an option of going into a combined program of pediatrics and genetics. But then when I did the pediatrics, my first sort of selective or elective, it was in genetics. And I really didn't feel that's the place I wanted to be. My knowledge of going into genetics was mainly how exciting the field of genetics is in general. However, during residency, I certainly started looking at what other specialties, if not genetics. I love general pediatrics in general. But I also liked that when I started in GI, the procedural aspect of it. And interestingly, as I mentioned about my genetics, immunology, and IBD kind of, is a perfect match if you really think about it. The influence of genetics, influence of immunology, which was one of the fields that I always loved during my medical school. So it's sort of, marrying between all of these came about being an IBD specialist. On top of that, as most people in medicine will tell you, that their interest also is driven by their mentors, whom they see as they want to be, right? So I had wonderful people during my training. So one of my IBD specialists in Milwaukee was just a phenomenal individual and a really smart guy. So I said, I want to be like him. And so I started my journey during the first year of fellowship, thinking about, within 6 months, I knew I wanted to do IBD. And then it so happens that I met this immunology faculty during my first year of training as a part of patient-related evaluation. And I just approached him and asked about his lab, and so joined his lab for the next 2 years, and rest is history. So I basically pretty much got trained as a gastroenterologist, immunologist during during fellowship.
That's a lot of school.
Well, yeah, that's right.
But I'm really glad you brought up genetics, because when I was looking you up in PubMed, you do have a few publications related to genetics and looking at the genetics of children with inflammatory bowel disease. So can you talk a little bit more about your research in this area? And because I know we still have a long way to go before we figure out the genetic.
That's right. Although those publications come up as genetics, it's more on the immunology side that I worked on those papers. I have 2 publications, clinical-based publications on genetics related, but it is the immunology aspect I contributed in those papers. So, as you know, like IBD is sort of is a multifactorial disease. It's a contribution from genetics, environment, and environmental factors, and the immune system interplaying between these 2 factors, leading to the inflammation in the intestines. So, there has been significant advances, if you look at over the past a decade or so, that we understand much more about IBD than what we did in the past, including the, role of several, genetic polymorphisms or mutations leading to intestinal inflammation. Likewise, we also learned more about the influence of environment through microbiome, leading to hyperactive immune system in the GI tract, further causing this intestinal inflammatory disorders, of which Crohn's and colitis always are on the top. Okay, and if you really look at the understanding also came from studying patients who had inflammatory bowel disease at a very young age. So that's one of the specific cohort of people that I am very passionate about taking care of, and we run this multidisciplinary clinic, which involves an immunologist and a dietitian, where we see patients who have very early onset inflammatory bowel disease, which is under 6 years of age, and also those who have underlying established immune deficiency disorders, but have gastrointestinal problems. It is, as I mentioned at the beginning, that GI tract is the biggest immune organ of the body. So if you think about it, any immune disorder, more than likely those patients may have GI manifestations. And we recognize that, some of these patients, their first attention, they come to a doctor or a physician, is manifesting IBD. So this kind of clinic really sort of helps to uncover if there is any underlying immune deficiency disorder that may require management somewhat differently than how we manage conventional IBD patients.
Talk a little bit more about that, because how do you discern that it's not inflammatory bowel disease when you have a patient that comes in that is exhibiting these symptoms?
That's a great question. So IBD in general is considered an idiopathic disorder. Means you cannot say that, there is one test that will tell you it is IBD. So it's pretty much the way we make a diagnosis is combination of, clinical features, laboratory abnormalities, and then what we find on the colonoscopy, and ruling out certain things. So that makes a diagnosis of IBD. So now when you look at very young patients who present with this combination, you really have to think about, is there something else that might be manifesting as IBD? So, as I mentioned earlier, that IBD is considered a sort of a multifactorial disease where you have genetic influence, where you have environmental influence. So when you see those in very early in your childhood, then you really have to think there's not much of environmental influence this child could potentially have had. So you really have to think that the genetics play a significant role. And that's what studies have shown. So, younger you are, there is a more influence likely from the genetic component compared to conventional or older onset IBD.
So if somebody is diagnosed very, very young, under 6, does that change the course of their disease? Does it mean that they're going to have a more aggressive disease course? Does that predispose them to fistulas or the sort of other things that go along with, especially Crohn's disease? So does it just make it a lot, does it make it a lot harder to deal with?
We really don't have a perfect answer for that because number one, it is a rare thing for under 6 years of age patients that present. So, and there's actually one or two studies looking at this particular population. The numbers are so small that it's hard to come to conclusions. But in general, they do behave somewhat differently in the sense that they have severe disease. They may not respond to the conventional medications. And number three, that they may not respond to the doses that we use in a regular IBD patient. They may need higher dosing. They may need combination of medications. They may need approach that, is slightly different. That one thing is for certain is all of these under 6 years of age patients will need workup, and involving an immunology specialist is extremely important in taking care of these children, because sometimes we use medications that are not necessarily used in inflammatory bowel disease in these very early onset patients. I hope I answered that question, but as I said, we really don't have enough data to really conclude, but in general they are sort of follow a more serious course.
So you just said that you may not use the same medications, but we know pediatric in general have fewer medications that are approved
That's
to
correct.
use. So are you using medications that are approved for adults in these
Yes,
very early
yes.
onset? Okay.
Yeah. So we, in general, like if you talk to any pediatric specialist, they'll tell you, at least more than 1/3 of the medicines they used are not FDA approved for children, and they use them off-label for managing children. It's, one of the things about medicine is that because children are vulnerable population, they're not typically are the ones medications are studied right away. So it's good and bad in one sense, bad in the sense that it may take, a decade or longer after a medicine is approved in adults to get approval for pediatric population. So the answer is yes, we do use medicines that are not necessarily approved for children, but approved for adult IBD. But we also use medicines other than the conventional IBD medications that are used in adults too. So for example, there are, at least a handful of patients that we follow in the clinic that came to us as IBD, inflammatory bowel disease. But after genetic testing and immunologic testing, we kind of found that they have a different set of mutations that may respond to a medication called Orencia, for example, or abatacept. So that gives two advantages when we do such an approach. Number one, you don't expose these medications to, potentially, you don't do the standard approach of trial and error. You directly go to most effective medicine. Otherwise, the conventional approach is you start with IBD medications, they don't work, then you keep exploring the next level. So this approach really, it's sort of a personalized and patient-specific medication approach. And similarly, we have, a couple of other patients where instead of trying to start with like infliximab or adalimumab, we go to like immunosuppressive medications that are typically used in rejection, for example, tacrolimus or sirolimus.
That's really interesting. Of course, the first thing that popped into my head is how do you get the insurance companies to pay for stuff that's off label?
Yes.
But maybe that's a whole conversation for later.
Right. Yeah.
Right. That's correct. It's so, at least I would say every week I'll write 2 or 3 letters of medical necessity where we have to summarize why, this approach is the best approach for the patient. And, invariably we expect to talk to a doc, like insurance doctor calls us, and then we explain in person why, we shouldn't be taking this approach. We likely are going to make the child sick, and, we have to use this medicine before we go there. And a lot of times we'll be able to convince, but there are times we do have to struggle and go through a little bit of difficulties, but fortunately we do get there.
I'm happy to hear that, but it's annoying that you have to even go through that process to get the child what they need. I want to back you up just a second because I'm super curious now. So let's give you a hypothetical patient. So hypothetical patient walks in the door with their parent or toddles in the door, depending on how old they are. And they've been referred to you by somebody else. They say, we think this is Crohn's disease, but you run genetic tests, you scope, you look at the child and you go through their history. You don't know that it's Crohn's. You're still you're not convinced. how do you make the choice on how to treat that child at that point? And
Yeah.
actually, no, hang on. I'm going to back you up even further. What tests do you do for the child? And then how would you decide the type of treatment to do?
Yeah. So first of all, I think with this, immunologic and genetic testing, we do not do on every patient. We do this in those who have very early onset disease, or if they have, other autoimmune problems. For example, if they have, diabetes, if they have arthritis, if they have severe eczema, then we think about, maybe this is much more than, conventional Crohn's disease or ulcerative colitis. And so based on that, if let's say if it is a regular 17-year-old that walks into my office with a diagnosis of Crohn's disease that is not responding to your treatment, then I obviously will look back into his chart and see, what is going on? Is the diagnosis correct? Number one. Number two, what medicines have been tried and whether the medicines have been given at adequate dose. If the dose was adequate, were the levels measured, saying that, patient specific. So, do we need to adjust the dose of that medicine? So if let's say the answer for all of those questions is, yes, this is Crohn's disease. Yes, this is the right choice, first choice medicine, and that the dose is correct and the levels are good, then we basically, try to, and then the other thing we really have to ask is, are the symptoms that the patient coming in with, are they really related to Crohn's disease? So we kind of have to answer all of those questions. And then once we say, if we are not sure about any of those answers, we sometimes have to, unfortunately, put them through testing again, including sometimes endoscopy, colonoscopies, and then make a decision, how to move forward with. But in general, let's say, if I understand your question, the other way is, how do you decide of the Crohn's medications, which medicine to start, correct? Right? So that sort of depends upon, whether we are dealing with Crohn's or ulcerative colitis. There are some medicines that may not really appropriate for Crohn's disease patients as opposed to ulcerative colitis. Likewise, what severity of the disease and which part of the bowel is involved. For example, patients with perianal Crohn's disease, we have to directly go for anti-TNF medications. For example, infliximab or adalimumab. In patients who have milder colonic disease, we can, potentially start with things like, 6-mercaptopurine or methotrexate. Although most of our groups practice, and you would say, pediatric practice, we also start them on anti-TNF medications instead of going through immunomodulators. Likewise, if it is a ulcerative colitis patients, my approach is, always to start with 5-ASA medications. These are anti-inflammatory, topically acting with least amount of side effects. So we try to give them a chance to respond to those medications.
Okay, that's very helpful. If you don't mind sticking with genetics for a little bit, because one of the things I wrote down based on the articles I found for you was chromosomal abnormalities and deletions. That's all I wrote down. So I sure hope that you can tell me why I would have written that down. So clearly I didn't finish my thought.
So the way that article came about is, so basically, when you really look at all the genetic studies that have been done in Crohn's disease, then most information comes from these studies called genome-wide association studies. So what these are, you basically take, for example, 1,000 patients with Crohn's disease and 1,000 patients without Crohn's disease, and do genetic sequencing on both the groups and see which genes come up as a really different compared to the general population. So all of us carry some of the other mutations. These are called polymorphisms. But it appears that, certain polymorphisms or these gene mutations are detected more frequently in patients with Crohn's disease. And thus, you kind of calculate the risk associated with each of those genes. If you have those genes, how much risk does that give you to develop Crohn's disease, for example? So that information is what we have for saying, okay, there is a genetic predisposition from Crohn's disease. But there is not many studies looking at, more rarer things. for example, the chromosomal deletions or duplications. These are large chunks of genes that are like taken out of the chromosome, or the entire chromosome may not be there. For example, in Turner syndrome, where it is instead of two X chromosomes in a female, they only have one X chromosome. That's what makes it a Turner syndrome. So what happens when you have those kind of bigger deletions or duplications is what this study basically we try to ask. But my contribution to this particular paper was truly not any of that chromosome deletions or duplications. My contribution was one of our own patient who had a gain of function mutation, means all of us carry two genes, one from mom, one from dad in each of the genes. But this particular patient had three of the genes related to one particular gene instead of two. So it's called gain of function mutation. So that's what we picked up on the genetic testing on this particular patient. And we collaborated with the folks at Oxford and did this paper.
You were part of another study, or UT Southwestern was part of another study where they came up with sort of a care pathway for kids with Crohn's disease based on some testing. And I believe it was genetics, wasn't it?
No, it's the risk study. I was not part of it. It was my colleague Ashish Patel. He was here until 2020, and he, went to Phoenix Children's. But yes, the risk study was, really instrumental in looking at several things, including, genetics and some microbial signatures and influence of the race on, severity of the IBD.
But we're not to a point where we can have a genetic test that says, yes, you have inflammatory bowel disease yet.
No. So there are these tests, combination of tests that will tell you probably, whether you have Crohn's or whether you have ulcerative colitis. But those tests have several limitations, including the fact that, the ability of those tests to tell somebody with Crohn's disease that they have Crohn's disease is about 6 out of 10. That also means that those who are healthy may also have those tests positive. Okay, that doesn't mean they have Crohn's disease. So it's a combination of antibodies to certain bacteria, presence of certain mutations and things like that. The way simplest way I explain to people is that the risk for celiac disease, the mutation that puts people at risk for celiac disease is present in 40% of whites. But not for all the 40% have celiac disease. Only 1% of white population has celiac disease. So similarly, these tests have several limitations. So in my practice, how often do I order those tests? Almost never. But in general, some people do find them useful when there is a question about whether I'm dealing with Crohn's disease or ulcerative colitis after doing all the other tests, including the endoscopy, colonoscopy, and everything else.
Got it. So it sounds like, based on kind of what we know about this and a lot of other autoimmune conditions, it isn't just showing that you have, like you said, this genetic predisposition to it. It's that you have that, plus you layer on environmental and all of these other factors, and that's potentially the perfect storm of creating disease.
That's correct. It's also interesting that, I brought up celiac disease. That's why I'm kind of bringing this up too, that several of these polymorphisms overlap with other autoimmune diseases, for example, lupus, rheumatoid arthritis, celiac disease, as a matter of fact. There's an overlap of these, mutations or polymorphisms. It's almost, partly this was part of my research project as a fellow or actually when I was transitioning from fellow to a faculty member in the Medical College of Wisconsin, where I was trying to sort of explain this more in the form of, you have a predisposition to autoimmune condition, and that based on, certain other environmental factors, you may develop Crohn's disease, you may develop asthma, you may develop celiac disease, you may develop rheumatoid arthritis. So pretty much, these polymorphisms do predispose to you an autoimmune condition, but there is a significant overlap.
And I guess that kind of explains why some of these medications that they use to treat IBD also treat like rheumatoid arthritis or other types of autoimmune conditions. Okay.
Yeah.
Somehow this makes me less hopeful, but more hopeful at the same time. I'm kind of bummed out by this, but also but maybe that's means that if there's a way to use something like gene editing to edit that out, that maybe it helps cure a lot of things instead of just one thing. So I can dream.
Yeah, so absolutely. We have to be optimistic, But, there was a speaker at a conference, I think a couple of years ago. He said, okay, cure Crohn's disease. I don't believe so. End of my talk. And he sort of walked down to the podium. But, I think, there certainly is quite a bit of advances in managing Crohn's disease, but in general, Crohn's disease is considered a multifactorial, etiology. And as such, it's not one gene that causes Crohn's disease. So if it is one gene, gene editing might really help. That has been done in several other genetic conditions, but this is, considered a multifactorial disease. We know that close to 200 plus genes have been identified to predispose to Crohn's disease. Even if you combine all those 200 plus genes, the risk those combination will give you is about 25% explanation of why somebody develops Crohn's disease. So it's much more complex, Yeah. And it's also, there is a domino effect too. It's one of those things, the body is so complex that you fix one thing that you may actually make other thing worse. It's much complex than, what we really think.
Yes, it's so lovely living in that body too. When you fix one thing and then something else goes wrong.
That's right.
I'm going to ask you a question because I read an article, and this is just a regular article. It's not like, published research or anything, but because you said genetics, immunology, and gastroenterology. So I read an article today that said that we're starting to change the way that we talk about Crohn's as an autoimmune disease, but it's an immune-mediated disease, an autoinflammatory disease, and not an autoimmune disease. What is that?
It's, I feel it's purely whom you talk to.
Okay.
They kind of can replace the terms. I mean, they can be used interchangeably. So
Okay.
autoimmune typically means your immune system. Auto is self, immune is immune system. So immune system acting against itself. If you think about, IBD, although it's much more complex than saying, okay, your immune system is attacking your own self. Because in IBD, as we understand, the trigger that happens is, at least so far what we understand, that there is change in this microbiome and that our immune system sort of starts attacking the microbiome, and that there will be much more damage to the lining of the intestines. So typically our intestines are like sort of only certain antigens will cross the barrier, get into the bloodstream, exposed to this immune system. With the break in the barrier, there is a big, sort of inflammatory reaction there, leading to further damage and leading to IBD. So, it is sort of autoimmune condition in a way, if you really think about it, that it's your own immune system causing damage to the GI tract. But here, the original fight was potentially not against your own body. It was against the bacteria, but, sort of an innocent bystander, the intestinal wall gets damaged. So in that situation, you can say, well, it can be autoinflammatory too. It's hard to really, but most people use those interchangeably.
Tomato. Thank you so much for clearing that up, because I was reading that and I'm like, what? It sounds very similar to me.
Yes.
Semantics.
That's correct.
So the other thing I wanted to ask you about, because I feel like this is very popular amongst our folks, is you do have a paper out there about fecal matter transplant and using it for kids, especially with ulcerative colitis, I believe. So talk a little bit about that and using that as a therapy.
Yeah. So it's fecal microbiota transplantation, or FMT. Yeah.
Thank you.
Yeah, it is, well recognized as an effective way of managing Clostridium difficile infection, especially if it is a recurrent Clostridium difficile infection. But the results on ulcerative colitis are all over the place. So there are some studies that show that it is effective, some studies that show that it is not effective. But most of the studies use it in combination with medications. And the other thing that is not clear and variable among studies is, how many times do you do the fecal microbiota transplantation? Because it's not one time that most of these studies look at, like doing this multiple times. And, what kind of and whose microbiota do you use? So those are quite variable results. And the third problem is that it appears to be more of a transient effect. It is not a long-term solution. See, and it's understandable why it cannot be potentially a long-term solution, because, microbiome is not something that, sort of you can give and it settles down in your body and that it won't change anymore. It is influenced by what we eat, what we put in our GI tract. So, if you take a microbiome from a person who is, purely on a, let's say in the Amazonian forest, some tribal, there are studies looking at that. So take the microbiome of that person and put into someone who is eating Western diet. That microbiome may not sustain there for long because, it's not, you need to have a substrate that this microbiome can survive on, right? So if your diet is not the same as a person who is giving you the microbiome, then you cannot expect that microbiome to stick around in your GI tract for long. So if it doesn't stick around, you don't expect that to work for long term, you see. So there is that, complexity to the microbiome. And the other things that we don't understand is that, and there are some studies actually looking at this, that is it the bacteria that is really beneficial? Is it the viruses that are really beneficial? Or is it the combination of those? Or is it really not the bacteria, not the viruses, but the products that are produced by this bacteria and the viruses that are really beneficial to you? So it's really ongoing research. In a way, I feel like FMT is a crude way of, treating any of these illnesses. It's like, although there is quite a bit of science behind it, but it is, there is a lot more refinement and a lot more questions that we need to answer before, we feel like how this works. We know it works, but we don't know how it works. I'll phrase that as saying it works in C. diff, but not in ulcerative colitis as a long-term solution.
Right. I mean, definitely that is part of my question on this is like, how do they select the donors for this? Like what makes your biome superior to somebody else's other than the fact that you don't have C. diff? I don't know. I don't think I'd be volunteering and or chosen for this, but I'm curious who is,
Yes. Actually when we started this FMT program for C. diff at Children's, so we were thinking about where to get the samples from, right? So ultimately what we decided is we went with this company in Massachusetts and we looked at how they screen. There is a big questionnaire. And actually, every time the donor gives the stool sample, first of all, you have to qualify as a donor based on all the questions you answer. And then you give them a stool sample. They will do the analysis to make sure that there is no infection, either bacterial infections that are obvious like C. diff, E. coli, Shigella, Salmonella. And they'll also make sure you don't have any parasites. You also don't have any viral infections. So they'll also check your blood to make sure you don't have, obviously HIV is one of them. So several other things. So they'll make sure they get screened for all of these, and then they will be eligible to donate the stool sample. Believe it or not, from that particular company, the donors got $40 per stool sample. If I was in Massachusetts, I would have totally taken that opportunity.
Heck yeah, that's an easy $40.
Yes, indeed. How many college students were going and donating or
That's
trying
right.
to?
So these are all probably MIT students,
I mean, listen, I wouldn't mind getting a little bit of infusion of MIT stool. Honestly, maybe it would help. Maybe it would make me smarter.
Yeah.
But for FMT, so C. diff seems to be much more prevalent in the IBD community, and it seems like it's recurrent in the IBD community. Why is that?
Yeah, so I'll actually, go back to saying like, well, it is frequently detected in IBD patients. Now it is hard to say, C. diff is really causing a problem, at least in the pediatric population. In adults, I understand there are several studies looking at, well, the incidence of C. diff is higher in IBD patients, but in children, that may not necessarily be true. And there are actually studies looking at, healthy IBD patients means they are under perfect control with not having any symptoms versus those who have active symptoms. And if you check, what proportion of patients patients who have no symptoms are under control have C. diff positive and what proportion with symptoms have positive. In those particular studies, the difference was not much. Both of them were positive equally. So telling us that at least, we have to question that, if let's say they are detected equally, when you have a patient with symptoms and you have C. diff, how can you say it is the C. diff which is causing the symptoms, right? So it is a much more nuanced than saying, well, it's, increased and that's why it's the reason. Now, why it could be higher incidence in IBD patients is because they have one of the most important reasons why people develop C. diff infections is because of change in their microbiome. If you look at one of the most underlying problems in patients with IBD is change in their microbiome, right? So that is a very consistent finding in almost every single study that the microbiome in IBD patients is sort of, abnormal compared to the healthy controls. If you think about C. diff infections, one of the most important risk factors for C. diff is being exposed to antibiotics. So if you're exposed to antibiotics, the risk of C. diff infections goes up. The antibiotics are known to cause change in your microbiome because they just don't kill the bacteria that they're given for. They're also, pretty much kill other bacteria they can.
Okay.
Right.
This may be a really stupid question. If being on antibiotics increases your risk for getting C. diff, how come the treatment for C. diff is antibiotics?
Because C. diff is an organism. It's an infectious organism. You see, the antibiotics we use for C. diff infection, again, not only attack C. diff, but it also, sort of can be detrimental to good bacteria in our gut. So you basically use what we have.
So is there a way to mediate that? Because certainly taking probiotics seems like it's the right thing to do, but also getting the probiotics to go where it needs to go, I know is a bit of a challenge. So how do you mediate this?
Yeah, so, there are ways to decrease C. diff infections, which is, first of all, avoiding antibiotics for things that you really don't need to. This is something that if you go to primary doctor's office, like either internist or a pediatrician, at least in my internist's office, there are always boards saying all fevers don't need antibiotics, all colds don't need antibiotics, all coughs or bronchitis may not need antibiotics. So, those are the things to be really careful of, saying, why you need antibiotics are 100% life-saving medications, but you need to know why you're taking an antibiotic. Second thing you could do is try to take, probiotics to decrease the risk of antibiotic-related damage to your gut microbiome. So there are certain probiotics which have been proven to be beneficial. I typically recommend my patients, to do yogurt or kefir, which is a fermented yogurt drink. And then I also recommend them to do something called Saccharomyces boulardii. It's a specific kind of probiotic, or Lactobacillus GG. So those are the, you have to know also how much probiotic you're giving to all these patients.
Okay, wacky idea. What if we were to incorporate the probiotic into the FMT and deliver it all at the same time?
Well, FMT is a probiotic in a way. So
Yeah, but stir some of the other stuff in there too while you're stirring it up.
Well, I don't know. It's like FMT is a combination of all the bacteria that reside in the human GI tract, that bacteria, viruses, whatever it is. So you're basically giving the, entire community of organisms. So that's like giving probiotic.
I'm still going to go patent this just in case.
Okay.
Just going to put it out there. I'll let you guys be co-inventors. Don't worry. Okay. So you mentioned internist and pediatrician. So what that makes me think of is all of the other types of healthcare that typically come from these types of folks, which a lot of times then ends up going to people like you once somebody has a chronic illness. I know in talking to a lot of our patients, and I think Robin would agree with this, that your gastroenterologist becomes your primary care doctor when you have inflammatory bowel disease. So how do you work with kids to get everything else they need? I know they call that sort of health maintenance in this world.
Yes, yes. So you're absolutely right. So, if you think about IBD patients, they see their IBD doctor or GI doctor way more than they see their internist or their primary care physicians. And, a healthy individual, like I see my PCP once a year, but whereas an IBD patient sees a IBD doctor at least 3-4 times a year, if not more. So then the patient identifies the IBD doctor as the primary care physician, which absolutely is very much valid in my opinion. At the same time, there are limitations that what GI doctor can do. But I would say that I get frequently calls on what to do about, like if they have a cold, what to do about it. If a family member has an infection, what to do about it. And I do tell them to call me if they have fevers so that, we can direct them appropriately. There are times that fevers may be caused by something we have to take seriously and start investigating. And it's always something that I always make sure is that I make sure that I keep the PCP also in the loop, so that access to care is much easier to a primary care physician than to a GI doctor. So that's when, we kind of direct our patients to go to the pediatrician and make sure that we communicate to the pediatrician. For example, during the COVID, I have received so many calls from my pediatricians to patients' pediatricians asking, like, what do you do? Now this is COVID positive. So how do I approach this? So we have, worked together as a team to send a patient for example, immunoglobulins, for remdesivir infusions, Paxlovid in some patients. So we have done that. And in most patients, we would say, well, you don't need to do anything. Just, let us know if things get worse. That's vast majority of our patients. Very few did we need to do any interventions. And the second aspect, which is, been there even before COVID and, still exists, is updating their immunizations. So this is part of the responsibility, in my opinion, of the IBD doctor to make sure that to pay attention to the vaccination that these patients are getting and making sure that they are up to date with their vaccinations. Number two, that they get additional vaccinations that they may qualify for if they are an immunosuppressive therapy. For example, pneumococcal vaccination. This is a recommendation for all IBD patients, whether pediatric or adult. If you're on immunosuppressive therapy, the risk of pneumococcal pneumonia is higher, so you need to make sure you update your pneumococcal vaccination. Secondly, making sure you have good response to hepatitis B, and if it is not so on the blood test, that you need additional vaccinations. And thirdly, making sure that they get their HPV vaccination at the right time to prevent, cancers related to HPV, human papillomavirus. Similarly, making sure they get annual flu vaccine, COVID vaccine, all of those things. And, the health maintenance doesn't stop there. Making sure we talk to our patients about skincare, melanoma, non-melanoma skin cancers. There is a increased incidence, being in Western Hemisphere. And as the pollution increases, there is increased risk. So it is recommended universally for every individual to put sunscreen on, but especially if you're on medicines that suppress your immunity, you absolutely have to make sure you tell your patients. So that's something we talk about, and we make sure that they see the eye doctor or a skin doctor periodically, like once every year to once every 2 years. And the other thing, talking about diet, my encounter with a new patient will never end without talking about diet. So we kind of tell them about, in general, which is advice that I give even for my non-IBD patients and my family members too, is avoiding processed foods, limiting or reducing the amount of red meat and trying to eat lots of, vegetables and fruits, high fiber containing foods, unless you have narrowing of the bowel. These are supposed to be really helpful. Again, it goes back to the principle that, what does your microbiome survive on? Purely plant-based food, high fiber containing food. So we kind of, talk about that. All of our patients meet with a dietitian at the time of their diagnosis and periodically after that. And then we also have to ask about their mental health. Having a chronic illness puts a significant burden on this patient population. And so it's something that we have to make sure we address them, get them meeting the psychologists. And we also talk about their physical health. Exercise, and there's more and more emerging literature that talks about, heart rate variability as a factor or as a measure to say how a person with chronic illness is doing. And it appears that what really helps a patient have a better heart rate variability is exercise. both aerobic and weightlifting exercises, resistance training. And that's also not just important for overall chronic health well-being, but also for their bone health, which is often compromised by chronic illness like inflammatory bowel disease and being on steroids. At times, these patients get exposed to steroids, and that will put them at risk. And if they're sick, they're not having much of a physical activity, and their nutrition is influenced. So that's where comes the health maintenance. So in a way, a IBD doctor's job doesn't end at taking care of inflammation of the intestines. It actually sort of, expands to making sure we treat them as holistically as possible.
This sounds like everything that I asked my GI for. Yeah, a referral to a dermatologist. I just got tested earlier this year to see if I was still responding to Hep A and Hep B, and I wasn't. So they wrote me orders to get Hep A and Hep B vaccine. So I feel like you're serving the pediatric population, but I do all of those things with my adult GI too. I do have a primary care doctor because I live 3.5 hours away from my GI. That he partners with me locally, but almost everything goes directly into my patient portal to my GI and her team.
That's right. So you have an excellent IBD doctor then. Awesome.
Yeah, I do. Yeah.
This is what I love about pediatric doctors is it seems like the pediatric GIs especially have automatically a little more holistic of an approach towards their patients. Like you guys have psychologists on staff, you have dietitians on staff, you bring your dietitian into your first consult. I really love that, and I wish it translated a little bit more to adult gastroenterology, because Robin is not your average consumer. She knows what to ask for, she asks for it, whereas you guys just kind of do it. And so I don't know, I feel like there's some learning that the adult GIs and or adult healthcare system in general needs to do.
Yeah, I think things are getting better as, people are recognizing the importance of diet and nutrition, not just in pediatrics, but also in adult IBD patients too. So I've seen some of the centers really incorporating dietitian as one of their multidisciplinary team in approaching IBD. Yeah.
Yes. And many are also adding mental health providers, which I think is super important as well, just because there's so much that can go into that.
Yeah.
One of our past guests is an adult now, but was a child when she was diagnosed. And she talked a lot about how sometimes the language that's used by the medical community can make failure seem a bit on the patient. So like when you talk about somebody failing a medication, versus the medication failing them, and about how, especially when she was as a child, that sort of things like biologics or surgery were sort of held out as like, oh my God, we don't want you to get there. So it feels like it's a real catastrophe when they get there.
Yes.
How do you make sure that the language you're using is not incorporating failure and fear into some of these.
Yes. So this is, one of the other things that I'm, really passionate about is the shared decision making. So, when I see a patient, I tell, well, what are your goals on, what do you want to see get better? And then I also tell them, like, what should be our target in managing this? Where are we trying to go by putting you on these medicines? So, for example, most of my patients, right after the scope, I tell the family and also I tell the child when I see them back in the clinic saying, hey, this is, how your intestines appear. So it is inflammatory bowel disease. And now our goal is to treat and get rid of all the ulcers in your intestines. Our target is, healing the mucosa of your intestines. And now how do we get to the target is by starting you on these medicines and reassessing whether we got there or not. And then if, let's say, after that reassessment, if we didn't get there, then we basically try a different approach. But I also tell them ahead of time, if let's say I'm using one medicine, it doesn't approach, I don't reach the goal, or I only reached part of the goal, then I may tweak the medicine or switch the medicine entirely to get to the goal. And so I feel like when you have a discussion this way, it's two things you're telling them: that what the goal is, number one, that although, symptoms will get better, but it's not that which we are focusing on. We are actually going abound beyond that to make sure you don't have any chronic problems that may come along if the the inflammation is not optimally controlled. And number two, you're also telling them that there is a chance that these medicines that we're going to try on you might not get us to the goal. Then we have to use additional medications. So, I hope I have not given that kind of an impression to any of my patients, but certainly we try to say it's like biology is different in different people, that we work as a team to get your disease under better control.
I love that so much. And that's exactly what I was going to point out. It sounds like you're really making it a team effort.
Yeah.
And it's not, the responsibility doesn't lie on any one.
That's right.
It's like it's a team effort. And if it's not working, it's not a person's fault. It is just the way the body is working, and we're going to try something else. I really, really love that.
Yeah. And I also, believe it or not, I have gotten many of my patients, they are so vested in this that they are very compliant with this approach. When you tell them, this is how we're going to get there. So I feel like the compliance improves.
Yep. I love that so much. But Dr. Gurram, we have been on here for an hour now. It doesn't even feel like that, but we have. So it is time for me to ask you our last question. If you had one piece of advice, it could be for your patients or for your colleagues in the medical field that are treating patients. If you had one piece of advice for the IBD community, what would it be?
Well, I would say that IBD for patients should be a part of their 1,000 other problems as humans we deal with. So, it is a problem, but like everybody else, faces the problem, you have to basically face that problem, and you shouldn't let that pull you back in what you want to achieve in life. And I always take the example of Kathleen Baker, who went on to become an Olympic gold medalist, for my patients, just to, tell them that, there are folks who won, who are presidents of the United States. They are in medical fields, several of them. There are, these elite sports champions. So I give them examples like that. So pretty much it shouldn't, hold you back on doing whatever you want to do.
That was a beautiful answer. I love it so much. Thank you so much for joining us today. We really appreciate you coming on the show.
Thank you for the opportunity. Pleasure.
It's been such a pleasure to talk to you and to ask you kind of some off-the-wall questions. I appreciate you taking those.
Yes.
And how fortunate your patients are to have you as a doctor. I just...
Agreed.
Oh, I would say I'm really fortunate that they trust me on their own child. I think that is enough said. Right.
You're such a joy. Oh,
yes.
Bhaskar, I love you.
Yeah.
Again, thank you so much for joining us, Dr. Gurram. Thank you everyone else for joining us as well. And so we're going to end by saying cheers.
Cheers.
Thank you. Cheers.
If you liked this episode, please rate, review, subscribe, and even better, share it with your friends. Cheers.